Hello, everyone. Thank you for joining us this week. Like always, we're going to take a minute to let the room fill up before we go ahead and get started. Happy Wednesday. Thank you all so much for joining us. We're going to just take a moment before we go ahead and get started. Let a few more people come in. Alrighty, let's go ahead and get started. Good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on global perspectives on hemophilia prophylaxis. My name is Alsa Murtha, and I'm the moderator of this series. This webinar has been pre-recorded, so there will be no live Q&A at this time. If you have any further questions for our speaker after this presentation, you can send him an email with Wednesday webinar follow-up questions as your subject line. Our speaker's email address will be added to the chat should you intend to use it. If you're joining us from one of our live streaming platforms, their email address will be added into the comment section. This webinar will be available to the community beginning this Friday. I am joined today by Dr. Joseph John. Thank you for taking the time to join us today. I will go ahead and turn it over to you to get us started.
Thank you, Alison. And it is such a pleasure to be in this forum, and it's an honor, I must say. And I must thank Dr. Valentino for inviting me for this Wednesday webinars. And the topic given to me is Global Perspectives on Hemophilia Prophylaxis. And I would like to take you through the journey of prophylaxis and what is happening across the income groups especially, and some observations on this of hemophilia prophylaxis, and a small survey-based study which we have done in India. Those are my disclosures. That's the overview of the talk today. That's a brief history, types and options of prophylaxis, global status of prophylaxis, a little bit of modeling on what would happen if you were to give all the patients 100% prophylaxis. Barriers to prophylaxis and overcoming these barriers. Taking the brief history, that is in 1992, the retrospective studies were coming out on the prophylactic treatment of severe hemophilia A and B. That's Inga Mary Nelson before the era of recombinant factors full-fledged available to the world. And of course, Dr. Aladot, who presented a longitudinal study of the orthopedic outcomes in severe factor VIII deficient hemophiliacs. Now, he predicted in the conclusion that how a full-time prophylaxis is likely to produce the best orthopedic outcome. Now, that's a critical point in 1994 to have considered that. However, we did not have any full-fledged studies to say that this is the the epitome of the evidence, the randomized controlled trials. Everybody went through the Swedish high-dose regime or the Malmo approach or the Dutch intermediate dose or the Canadian dose escalation strategy at various levels, mostly based upon the convenience and what a priori decision was made on what would probably help the patients. It is only in 2007 when Marco Johnson presented this prophylactic episodic versus episodic treatment to prevent joint disease came into being. Now, from 2007, we saw an increasing surge of continuous prophylaxis in the world. It is still not possible in many of the low-income countries. However, the seed of evidence were put in saying that prophylaxis is most important. Keeping the factor level more than 1% is going to make a lot of difference in the patients. And of course, now we have the 2020 guidelines. It is now 2 years old. Early initiation of long-term prophylaxis is the standard of care, whether it is standard half-life or extended half-life, especially with the age of below the age of 3 years. And of course, individualized prophylaxis should be considered to prevent bleeding for patients with varied activities. Of course, the pharmacokinetic monitoring is the most precise way to do that. It is possible in few patients, few parts of the world. There are various types of prophylaxis. To give you an overview, it's either a prophylaxis, primary prophylaxis before the second joint bleed. That means the patient has the first joint bleed and we immediately start the primary prophylaxis. And of course, the secondary and the tertiary is the late onset in tertiary, and the others are somewhere in between the secondary. The intent is essentially to prevent even one bleed, because the point is that the more the number of bleeds, the possibility of joint damage and hemophilic arthropathy is going to increase proportionately higher. From the prophylaxis point of view, if we have to do a standard of care over episodic, it is a long-term standard of care. Continuous prophylaxis is what is recommended. Target bleed is zero bleed is the dream. Whether it is possible or not is a matter of debate at various points. The trough levels of less than one, keeping it more than 1% was the goal of therapy so far. However, with the availability of extended life factors, we are able to maintain a much higher, in fact, 20 and 30% factors, and making them almost normal. So human aspirations are incremented. From a point of view of getting out of the bed and able to walk, they said, I want to, off the crutches, they said, I want to be able to walk off the crutches. And now off the crutches has become, I want to run. And now it is, I want to take part in sports, maybe even contact sports. So that's the kind of aspirations human beings have. And that is what has driven the humanity to improve upon what we already have. And we are seeing that in a significant proportion, in the momentum in hemophilia. And that's good for everybody, for the physician and for the patients. So now we have the standard half-life, extended half-life, and non-factor replacement therapy coming in as prophylaxis. And very soon we would have gene therapy coming in picture there to compete with non-factor therapy. Let's look at a global status of prophylaxis. Most of the data would come from this annual global survey, but it's important to glean onto these numbers a little more detailed. And I would like to give a little bit of perspectives on a few sections of the survey which dealt with prophylaxis. So this is the data from 145 countries. And this data global survey has been coming there since 1999. And that's the distribution of bleeding disorders across the world. In this survey of 2021, there were 118 respondents across the globe, almost representing all the continents. That's the distribution of the severity of hemophilia in the high, upper, and low middle income or low income countries. What do we observe here? We observe that the blue is severe and green is mild. Now concentrate on the mild and you see that the percentage of mild hemophilia is reducing across the income groups. The proportion of mild is reducing from high income to low income countries. Severity almost remains the same. So where it is losing ground on low income countries is less of mild and unknowns. Now that reflects the diagnostic capability of these countries. People with bleeding disorders across the globe has been increasing. As you see on the y-axis, you are seeing the number of patients. And on the Y2 axis, you are seeing the world population. And as the world population is increasing, the proportionately number of patients diagnosed is also increasing in all the three groups of diseases, that is the hemophilia A and B together, von Willebrand's and other bleeding disorders. But even though the proportion of increase of the world population is a slight slanted graph, the improvement in diagnosis is increasing, which means that we are catching up on the number of diagnosed patients across the world. People with hemophilia together is about 233,000. For a moment, let us keep this figure in our mind. About 2 lakh patients identified with hemophilia. Even that number is very low, and across the globe, it is only 30% of the patients who have been diagnosed with hemophilia. This is coming from based on a prevalence study of 20 PWH per 10,000 males, which means 10 patients of hemophilia per 5,000 males is an estimate, or 20 per 10,000, 20 per 1 lakh males. When you see that in the Eastern Asia, that is most of the low-income countries, a lot of low-income or low-middle-income countries are in the Southeast Asia, and you would see that the Southeast Asia is only 17%, whereas in Africa, a lot of countries are low income, not LMICs, that is 8%. And you see that in the Americas and the Eastern Mediterranean and Europe and America put together has the maximum number of patients who have been diagnosed with hemophilia. Now, that is simply a proportion of the developed and the human developmental index, where there is the income, per capita income, and the education and the life expectancy put together there. This is another observation I want you to know, is that currently we use about 9.8 billion units of factors across the world, when we have about 7.3, 7.4 billion population. So if you look at the whole world, we use about 1 to 1.1 unit per capita of factor 8. PWH, however, is diagnosed as only about 30%. Therefore, it is reasonable to think factor utilization per patient rather than per capita, because per capita is a false assumption which encompasses the whole population in the denominator. So let's think for a moment that each patient across the world is able to utilize 41,000 units per annum. Keep that figure in our mind. The per capita utilization is one option, one aspect. When you look at the perspectives of utilization, we must also understand who consumes most factors. This is the population percentage distribution. Southeast Asia is about 36%, Africa and Southeast Asia put together is about 50%. However, we see that Europe and America is put together utilizing 76% of the factors in the world. From the region, we are now looking at the income groups and the utilization. So, of course, the high income groups utilize about 60% of the factors, whereas the low income only about 0.3% and upper middle income about 33%. That's a population distribution. I want you to have a look at the high income groups are about 18% population, using 57% of the factors in the world. Low middle income has 59% of the population, using 8.8% of factors. That was population. Let's go a little more granular on the PWH perspective. The PWH diagnosed in high income is much more, and therefore, even though the population is less, they are consuming about 58, that is about 1.5 times. LMICs, even though the population is 57, the diagnosed is only 35%, I mean, PWH percentage is only 35%, not the diagnosed percentage. Diagnosed percentage is 17%. So that's again it's about 0.7 times only they are using. So that's the disparity we must appreciate when we are talking about different perspective of prophylaxis. Now comes the median global factor rate per capita utilization. So on one side, we talked about utilization of factors per patient. And now we are looking at per capita, assuming the proportion of patients diagnosed are similar, but it is not. In this per capita utilization, we realize that the low-income countries have very less utilization of factors as compared to a high-income country who is using about 5 to 5.5% there. This is an important understanding we must know in the process. What the WFH recommends is minimum target of aspirational should be 2 units per capita would be reasonable to use. So that is the number which I showed earlier also from total PWH versus current usage of factors, about 9.8 billion. Global prophylaxis status, if you have to look, I downloaded the global survey reports and did a Power Query analysis for stratification and a meaningful interpretation. That means less than 18 years and more than 18 years and income groups GNI. And when you look at this, you realize that global prophylaxis wise, 62% of the children less than 18 years are undergoing prophylaxis. Whereas more than 18 it is only 45, and combined about half the patients are on prophylaxis across the world. That's a distribution of less than and more than 18 years across the income groups: high income, low income, upper middle income. So 1, high income; number 2, upper middle income, low middle income, and a proportion of the patients who are undergoing prophylaxis are in tune with the income groups. So obviously a lot has to do with the GNI of the country. So that's the precise and estimated together is about 62%. And it is the 18% high income that's in a different form of presentation on the percentage wise. When they gave out the questionnaires, people were looked at an estimate and precise subsequently. We understand the overestimation bias, which is there when you ask for an estimate. And that's important to understand the disparity there. And in terms of coverage of prophylaxis, and that's a combined version of the average GNI of the high income countries versus the average income of LMIC countries. When you have a $37,000 per capita GNI, here we are looking at $2,000 per capita GNI versus 847. So therefore, it is reasonable to understand that the proportion of factor prophylaxis among the population would be directly proportional to the GNIs. Once you understand this, it is a no-brainer to understand that the affordability is the key factor which would play for the prophylaxis to be offered. Then comes the adherence and the compliance issues of people who have and would not want to do it. Taking a peek at the patients older than 18 years, we understand that older the person gets, the chances that they will be compliant and adherent to factors are less, and therefore it is natural for the number to be less. So high income 67, we had a parallel was 83 in less than 18 years, and similarly all of them have dropped by about 20%. This is the estimate and the precise of less than 18% factors, more than 18% group. The same as I mentioned earlier. Now comes suppose we were to model for the requirement of factors for the world, and this is a modeling which I mentioned. If all the patients who are currently diagnosed, who were to undergo a low dose prophylaxis, which means 2000 units per kg per annum, we would require a 38% increase. Whereas if they were to go for a high dose prophylaxis or intermediate dose prophylaxis, we would need 4 to 6 times the factor requirement what is available in the world today. So 9.8 billion is what we are using now. But if we were to use at this proportion, that's a percentage of rise that might ensue. Now comes the situation of how to evaluate for some of the barriers of prophylaxis. We sent out a questionnaire to many centers in the country, in India, and we asked them for operational barriers to continuous or intermittent replacement prophylaxis. So what barriers they thought are playing up to offer patients with continuous or intermittent prophylaxis, basically because the continuous prophylaxis in India is about 4 to 10% only across the country. The highest number was availability of factors, accessibility of factors, and of course, sustainability was an issue, even if they were available and accessible. Affordability is a major factor. However, the government is making measures to give free factors to many states in the country. So availability, accessibility, affordability, and the AAA and the sustainability and cost, that is also anybody could have thought a priori would be the possibilities. Then we looked at, that is from the operational level, caregiver level. Now from the patient level, they thought that the fear of inhibitors were number one. And that is a genuine fear in India, especially. That is because it's a misplaced fear. They think that if they give factors, the chance of inhibitor development is high. However, when the inhibitor develops, there are no alternatives which is affordable they can sustain. However, with some of the non-factor therapies being available in the country and being available freely, especially in children, many are coming forth. We are in the process as a country in various pockets. Home care therapy is being promoted, and that's the way the LMICs would improve upon when we tell the patient community that continuous prophylaxis is the need of the hour and you must do it. Venous access difficulties were some of the other parts, and non-adherence and non-compliance were there, especially in the older groups. So fear of developing factors, number one, venous accessibility, non-adherence, lack of transition program, and the lack of knowledge. Now, lack of a transition program is a genuine problem for even thalassemias like hemophilia. That part of the patient community is kind of often left at a no man's land. However, there are efforts with more clinical hematologists coming who can handle both pediatrics and adults are coming in and filling the gap there. How do we overcome these barriers? One is humanitarian aid, which is already happening, which has done a good job in various parts of the world. However, that is able to provide only 2.8% of the 9.8 billion requirement of factors. There could be stakeholder strategies. We need to evaluate the government, empower the government, educate the government for increased fund allocation, steady supply of factors, and application for HTA. I'm sure more of pharmacoeconomic studies and going to educate the government on the trade-offs which we would get and the potential advantages in long-term earnings, which can be contributions the hemophilia patient can make, would be one of the ways to take forward. And of course, doing proper cost effectiveness and cost utility studies. At the patient level is education and counseling, training for self-infusion. At the provider level, it will be sensitization, reinforcements, training the health care nurse coordinators. Here is one aspect, as I said, the provider level understanding and knowledge of you doing a here is not there. And promoting low dose therapy as much as it's available and affordable. At industry level, the competition is increasing. From what a factor cost was about 30 rupees for Indian standards few years ago, it has become 7 rupees, which is 1/4 or 1/5 the cost today. That is because there is competitions from extended half-life factors and non-factor therapies. And of course, we are going to deal with two major aspects to promote utilization of factors, which is advocacy and lobby. Advocacy will be the bottom-up approach, and lobbying will be a top-down approach with the legislators and the political knowledge to be done. India is doing a meeting. India has been doing some meetings across the last many years with both the stakeholders of the patient caregivers on one day and the political or the government machinery who are interested in this area to come and dialogue with the healthcare providers. And that has made a huge impact in the world today, in India today, in terms of fund allocation, because unless they are driven and emotionally connected to this, we need to use the art of persuasion there, the ethos, the logos, the pathos, and the kairos there, to get them to understand the need for prophylaxis. And that is what we are doing now at a macro and a micro level. And that is called a converging approach. When both these are done, and conflict of errors, conflict of interest can be reduced in this process once we bring them on the same platform and the motives and the intent is very clear from both sides. We will be able to then provide an inclusive and equitable care. Thank you so much for inviting me for this talk. I'll be happy to take some questions. Otherwise, if I'm not able to answer it today, or some of the questions, anticipated questions were not answered, please feel free to contact me on my email and I'll respond to you. Thank you so much. Over to you, Alison, for the next session.
Fantastic. Thank you. Just get my computer is taking just a moment. While I get that slide up, I'll go ahead and start with one question for you. So we noticed that severe hemophilia remains the same regardless of the individual's class level. Aside from access to care, was there anything else that may have impacted those numbers?
When you say the numbers, so you're saying that why was the severe hemophiliacs, even though they were symptomatic, were underdiagnosed in a country or
Yes.
in a LMICs?
Yes.
So apart from the accessibility, it is the expertise, the human resource that is developed required for making a diagnosis. So the laboratory training is the key factor there, and laboratories to be able to take part in quality measures, quality control programs, quality assurance programs. And that has been a huge thrust. There is a huge thrust being made by the Asia Pacific group and the Indian group, where continuous training opportunities are being provided for the technicians and the doctors. So that training piece would be the one which would largely going to fill this gap of underdiagnosis.
Great, thank you. What is the biggest takeaway you want the audience to walk away with? Oh, I'm sorry, go ahead.
Yes, please go ahead.
Oh, okay. What is the biggest takeaway you want the audience to walk away with from your discussion today?
To understand various barriers of prophylaxis in the country and across the world. Now, understand the disparity that exists between high-income countries and LMICs and low-income countries, number one. Number two, with regard to approaching and solving this problem would be advocacy and lobby. And for that, we may have to have some collaborative efforts. WHO may be roped in, where the Indian government then we have to rope in. We have something called National Health Mission in India. Like that, there may be various bodies in different countries in various continents who could be influenced through this advocacy and lobby.
Great, thank you. How do you anticipate global perspectives on prophylaxis to evolve over the next decade, considering the likely rise of gene therapy?
Yeah. So that's the how the landscape is going to change would be dependent upon how the non-factor therapies are going to come in. So of course, the cost of production of factor 8, that is recombinant, which is once established, it is not going to be so high. So on one side, when the non-factor therapies and the gene therapy is going to take over, and of course that those are going to be very expensive, the standard half-life factors are going to be cheap, and of course the high-income countries are unlikely to be utilizing that in large volumes. Of course, the industry would do a lot of maths behind it to see what is more profitable for them or what can be sustainable for them, even if it is to meet the needs of low-income and low-middle-income countries. So of course, those are factors which may come as humanitarian aid or a cheaper product in various countries. Of course, gene therapy, the major limitation is now the accessibility and the affordability part. And of course, it is also a major concern with regard to who can do and where it can be done. You have GMP facilities or not. And of course, the cart coming in and the gene therapy on various aspects coming up with CRISPR-Cas technology and the virus technology, this is going to skyrocket, I would think, with the expertise of CRISPR-Cas and how gene editing is happening in the world today.
Great, thank you. And my final question, as an international researcher, what does it mean to you to be able to present your work on a Wednesday webinar with a broad US and international audience?
It's a great honor to be part of this organization and to have an audience who are interested in this aspect of hemophilia care. And it means a lot to us in terms of collaborating with you, in terms of doing some studies and looking at the disparities. And of course, some new ideas may come up in this interaction. Can't hear you.
Oh, I'm so sorry.
Yeah.
I was muted and I didn't even realize it. But I'd like to thank you once again, Dr. John, for taking the time to join us this afternoon. We appreciate your time and your expertise. I'd like to thank each one of our viewers for joining us as well. Please note that this recorded webinar will be available on Friday at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon and have a wonderful week.
Thank you.